Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Örebro, Sweden, Professor Patrick Wigren. Prof. Wigren is the head of Department of Neurosurgery at the Örebro University Hospital in Sweden. He is a noted surgeon who is known for introduction of new services such as awake craniotomy, pituitary surgery, and aneurysm treatment in his university. He was the past chair of the neurosurgery at the Sheikh Shakhbut Medical City in Abu Dhabi, and he is an experienced consultant neurosurgeon and neurologist with a highly specialized profile in awake tumors and epilepsy surgery. He has over a decade held several of the executive and strategic positions in healthcare and professional organization. He is an experienced lecturer in the fields of neuro-oncology, epilepsy, neuroanatomy, epilepsy surgery, sleep medicine, general neurosurgery, neurology, and leadership. He was a previous member of the board of Swedish Society of Medicine, National Committee of Disorders of the Nervous System, National Committee of Stroke Guidelines, and the UAE Board of Neurosurgery. He is the president of the annual assembly of the Swedish Society of Medicine for 5 consecutive years, and we are extremely honored and grateful to him for accepting our invitation to be the speaker for our webinars, and today is going to talk about awake surgery in gliomas. The speaker for the second session of today's webinar is our honorable guest from Mexico, Prof. Juan Luis Gomez Amador. Prof. Amador is the founder and director of the skull-based surgery and neurosurgery and director of the Advanced Neurosurgical Training Center and professor and chairman in the Division of Neurosurgery, National Institute of Neurology and Neurosurgery, Mexico. He specialized his neurovascular surgery with Prof. Ghazi Yazergil, skull-based surgery with Prof. Osama Al-Mafti, and minimally invasive neurosurgery with Prof. Axel Porneski. He has held several important positions in career, like being the president of the Mexican Board of Neurological Surgery, president of the Neuroendoscopic chapter of Mexican Society of Neurosurgery, president of the Academic Committee of the Flank, and chairman of Neurosurgical Committee of the WFNS in 21-22. We are extremely honored and grateful to him for accepting our invitation to be a speaker at webinars, and today we'll be talking about endoscopic techniques applied to neurovascular cases. The chair for the first session of today is our honorable guest from Japan, Prof. Takashi Maruyama. Prof. Maruyama is a professor in the Department of Neurosurgery at the Tokyo Women's University Hospital, Japan. He is an expert in the glioma surgery, especially awake surgery. He has been treating brain tumors for over 20 years as part of the University Hospital brain tumor team. He has worked on projects with medical device manufacturers and other research facilities, developing new treatment methods, managing clinical trials, developing and approving new medical devices, and carrying out other projects. He also serves as the head of training department at the University Cancer Center and hosts the hospital's cancer board. He has participated as a staff member in the introduction of new model of stereostatic radiation therapy equipment developed in the US to Japan, and he is a noted researcher with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Prof. Patrick Wigren. The chair for the second session of today is our honorable faculty, is also from Japan, Prof. Fuminari Komatsu. Prof. Komatsu is a consultant neurosurgeon at the Bantane Hospital, Fujita University, Nagoya, Japan. He is an expert in the field of minimally invasive endoscopic surgery and specializes in the field of endoscopy for microvascular decompressions and several other complex neurovascular cases and brain tumors. He is a noted researcher with several publications in various period journals. We are extremely honored and grateful to him for accepting our invitation to chair the session of Prof. Amador. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Prof. Takashi Maruyama.
Hello, everyone. Good morning, good afternoon, good evening. It is great pleasure for me to chair this session. I appreciate this having opportunity, Dr. Raja and Professor Yoko Kato. Today's first talk is awake surgery, and the speaker is Professor Patrick Wigren. He is the head of Department of Neurosurgery, Örebro University Hospital in Sweden. He is focusing epileptic surgery and brain tumor surgery and also pituitary surgery. And I'm really looking forward to have this lecture from him. Please, Dr. Bergen, please start your lecture.
Thank you so much, arigato, for the nice introduction, and thank you for inviting me for this speech. I had the great pleasure of being part of the first team in Sweden who introduced awake craniotomy for gliomas over 15 years ago at another university hospital where I did my residency. I've also had the pleasure of performing awake glioma surgery in Abu Dhabi at Sheikh Shagbut Medical City, which was very interesting for me because prior to that, I only operated awake in Swedish and English, and in Abu Dhabi, which is a very international community, I had to perform awake surgery in Urdu, Hindi, Bengali, Arabic, English. So it was a great experience and challenge, but very rewarding also. I'm now chair of the Department of Neurosurgery in Örebro, which is, I will show you a map of where it is in Sweden. And I have the pleasure of also being both a neurosurgeon and a neurologist. I used to be head of the Department of Neurology at another hospital here in Sweden. This is Sweden. I hope you can see the screen. If it doesn't change, please tell me. Sweden is in the northern part of Europe, of course. Our healthcare system is divided into different regions, and we have 7 university hospitals, most of them in southern part of Sweden because that's the most populated part. And we are part of the middle Sweden region where we have 2 university hospitals, Uppsala and Örebro. This is Örebro. Sweden, of course, monarchy with the royal family here. A picture of our beautiful capital of Stockholm. So please come visit.
Prof,
Örebro is not that bad either.
Prof, there is a notification of Zoom. Can you just remove it?
Okay, let's see if that works. Yeah.
Okay.
It's gone now? Okay. So this is our beautiful city of Örebro, an old castle from the first 10th century, actually. Let's go into it. Awake craniotomy. Why should we do that? Well, of course, this is very basic to most of you, but just go through the basics as well. We want to reach a maximal resection of the tumor to achieve better survival, but at the same time, we want to minimize the risk of neurological deficits, which actually also leads to better survival, especially regarding motor function and speech function. The theory behind that, of course, is that if you get hemiparesis, for instance, you have a higher risk of infections and thrombosis. So the survival is actually higher with minimal neurological deficits. And of course, to achieve a better quality of life with more functions preserved. My good friend, Professor Dufour in Montpellier, who I published a few papers with, he always says that his first endpoint is not survival. The first endpoint is quality of life. He aims for high quality of life, and by doing that, he has achieved higher survival rates in the awake surgery group than in the sleep surgery group. There are some common questions and misconceptions. I think for the younger colleagues, this is not very controversial, but still there are some older colleagues questioning the value of awake surgery, awake craniotomy, especially in specific locations of the cerebrum. Some of them are, if you test too much, you will leave too much tumor. Why do you do it on the right side and not only on the left side? What white matter tracks should you know? This is maybe the most common question I get from younger colleagues. Should high-grade gliomas be operated awake? Many places don't do that. They just do low-grade gliomas. And how do we know actually that the tested function that we test during surgery, the specific test we use, is related to better outcome? If we test this function during surgery and we find it, how do we actually know that the test works, meaning that the function is preserved? Or how close can we go to this function in the brain? And also a very common misconception is that the awake surgery demand more resources than the sleep surgery. So what is the current evidence? I think I wrote /science because evidence is a little bit of a tough word to use in surgery. I mean, the strict definition of evidence, medical evidence, is that you use that in the context of evidence-based medicine, and that means that you should do randomized controlled trials. Very rarely is that possible in surgery, but that doesn't mean that there is no science. Science can be achieved in other ways than randomized controlled trials. If you look at low-grade gliomas and high-grade gliomas, for both of these groups, there is strong evidence that awake craniotomy gives higher resection grade, resulting in longer survival and higher postoperative quality of life. There is much more research on low-grade gliomas. And in low-grade gliomas, there is also strong evidence that cognitive functions such as speech, memory, executive function, social function, perception, visual fields should be preserved individually, tailored to the patient's needs. Of course, the most well-known research in this area is, there are many great, of course, scientists in this area, but a lot of these has been very strongly emphasized by Professor Defoe, of course, in his research group. I believe that there is more research regarding low-grade gliomas because you have a little bit more time to prepare to get the neuropsychological testing, and you're not disturbed by cognitive dysfunction preoperatively as much as in high-grade gliomas. So that is the explanation, I think, why there's more research in low-grade gliomas. But going back just a few years, there had been a rising number of meta-analysis and big studies also on high-grade gliomas. So it's coming there as well. And these are just a few important papers. This is the landmark paper by Defoe, where he actually very specifically showed that the survival rate is higher when you use intraoperative awake mapping. We've also seen now the last few years huge meta-analysis and systematic reviews on this topic. I can go back to this picture actually, because I think that the word eloquent is a bit, we can have that in discussion afterwards maybe, but that it's a bit dubious word, because what does that mean? What is actually eloquent in the brain? Is it the important functions, or is it the functions that you cannot recover if you injure them? It's not very well defined actually in the literature, the word eloquent. We have another big meta-analysis in 2018 when it comes to high-grade gliomas, so this evidence is also now strong. Another one. So there are quite a few now, big studies showing that this is the way to do it. And in this specific paper, they concluded, and this is by Dr. Q. Alfredo Quinones at Mayo Clinic, Florida, giving the effectiveness of awake craniotomy for resection of eloquent tumors, the data suggests an expanded role for awake craniotomy in brain tumor surgery, regardless of the location, which I think is very important to stress. There are a few very well-established intraoperative testing methods, of course, for motor function, which can be done both awake and asleep. Language speech function is very well, that we have very well-established methods. Association ability, also very well-established methods like the pyramid method. Perception, where we have the line bisection test. Executive functions, there are some tests there as well. And also for facial expressions, there's a well-established test to preserve the social ability of the patient, which might be very important for some patients in some professions, for instance. And just I usually show this image, which is, I mean, a very, very simple image. I usually show this when I have talks for medical students and younger neurosurgical colleagues. This is a schematic image showing two cortical areas, which I usually use the parable of a city. These are two cities, and between them is a white matter tract connecting these two areas, and I call that the motorway. And because I think it's a good picture of what will happen when you injure different parts of the system. This could, for instance, be in the brain, language, part of the language system. So the upper cortex area 1 here could be the frontal lobe, and cortical area 2 could be the temporal lobe. If you use the parable of a city, if you injure the sort of the outer parts of a city, the traffic on the motorway is not very much affected. Of course, if you destroy the entire city, it's affected. But if you injure parts of the city, you will not even be able to detect the difference in traffic between these two cities. But if you close down one lane on the motorway, you will have severe effects on the traffic. And it's the same way with the brain. So if you have an injury to a cortical area, the neurons will reorganize a little bit their function, and it will, after a while, you will not see any difference in speech. But if you injure the white matter tract, for instance, the acromion fascicle, you will have severe damage to, and also maybe permanent damage to the language system. And I think it's a way of understanding, a way of explaining to medical students and residents how important the white matter tracts are. There is plasticity in the white matter tract as well. You can, in more complex functions, you have different motorways doing different things, and they can find new ways to the cortical area. But the plasticity in the white matter tracts generally are much, much worse than in the cortical areas. And how do we know what parts of the brain have which functions? The oldest way was to look at lesions. This is, of course, a famous patient of Broca. This is how he defined the Broca area. However, what he didn't know was that the symptoms this patient had were not due to the cortical injury. It was probably due to the white matter tract injury below the cortex. So he sort of understood it a little bit. Of course, he's excused. It was a very long time ago. But then he defined, okay, this part of the cortex was injured, so that's also the area, the place where the language is formed. It's not really that small of an area in the frontal lobe that is involved in language. It might be the area most involved in the normal situation, but there are a lot of neurons around this area as well involved in language production. And in this particular case, probably it was the white matter tract, the arcuate fascicle underneath the cortex that was injured. More modern methods, of course. This is from an article, a publication, I think, by Dufault. This is where he has stimulated patients, stimulated the cortex of the patients, and he has seen different effects on the language function in these patients. And also, of course, in movement is also included here. And I think what's important with this image and other images like it is that those functions are quite variable between patients and quite widespread in the brain. We know that language function is in the frontal lobe and it's in the temporal lobe, but it can be very variable between patients. And another important issue here is that you get some of the patients have a lot of this function also in the right hemisphere. When it comes to the cortex, it's not that obvious that you have that much function in the right hemisphere. But when I believe that most of my colleagues who are doing a lot of awake surgery experience that when you get down to the subcortical part on the right, subcortical tracts on the right hemisphere, you usually get some language effects also in a very strictly right-handed person. So most of us have language function in both hemispheres, more or less. Another way to find out where functions are like this resection maps, where you look at a number of patients and you make an overlap analysis where you look, okay, patients with injuries in this part of the brain, they get this usually get this kind of defect, deficit. And then you get a hotspot, and you can find these white matter tracts in this way. Okay, if you have a lesion there, you probably will have this kind of symptom. So you match the symptoms to the defects on MRI. And of course, fMRI is also a way of finding function in the brain. A little bit about a warning about fMRI, though, is that you have to remember that it doesn't show function. It shows the ratio between oxygenated and deoxygenated blood, to be very simple. And it has a threshold. So if you higher that threshold, you will get small parts that looks active. But if you lower the threshold, you will have big parts of the brain active. And if you lower it to 0, the entire brain is always active. So it's a little bit warning about fMRI that it's a good help, but it's not the answer where the function is. And this is a question I quite often get from more junior colleagues and also from some senior colleagues who hasn't been part of this movement of awake craniotomy the last decades. Which white matter tracts should you know? Well, you should know that they are usually divided into 2 streams, the ventral stream and the dorsal stream. And the ventral stream is including the IFOF, the inferior front occipital fasciculus, the ILF, the inferior longitudinal fasciculus, and the fasciculus uncinatus. And in the dorsal stream, you have the fasciculus arcuatus, the arcuate fascicle, and the superior longitudinal fasciculus. And they are important. It's important to know these 2 streams because a lot of research is based on the dual stream system. For instance, when it comes to language, the dorsal stream is considered to be the tracts that are working with making a picture into a word. So if you see a helicopter, you can say helicopter. But to understand what it is, you need the ventral stream, which is the semantic stream. And then we have my favorite the last few years is a frontal ascending tract. I know that everyone who's into this field knows that it's been very trending the last few years, a frontal ascending tract. A very important tract which connects the superior frontal gyrus and especially the SMA with the operculum, and it has very important functions both in the left and the right hemisphere. Injuring the frontal ascending tract will give you a permanent or partly permanent SMA syndrome, which means hemiparesis and aphasia if it's on the so-called dominant side. But it has many other functions, and this is just a very simple picture of these tracts. This you should know. I think every neurosurgeon who is operating in the brain should know this, actually. You can know it by anatomy. I usually don't really need the tractography of the DTI. I know that this, for instance, that the arcuate fasciculus runs around this tumor. So for me, I do the DTI, I do the fMRI and all of that, of course, before surgery, but you should know where they are anyway. Here we have a patient that we operated, I think, in February. A young lady, very active, highly skilled professional with a big low-grade glioma. And what you see here is the red dot is the tractography for the arcuate fascicle. They're running over the tumor. And there is fMRI, and some, of course, surgeons not convenient, not very experienced in awake surgery would say, okay, you cannot do this really because there is speech function in the middle of the tumor. I'm not very scared of that. I'm more scared of the subcortical tracts. And in this particular case, we could remove the entire tumor. And I met her a few months ago during the summer, and she's back to work 100%. And the postoperative neuropsychology evaluation showed no cognitive defects whatsoever. She has a little bit what we call in Swedish brain fatigue. It's very common after all kinds of neurosurgery, cranial neurosurgery actually, but nothing measurable in the neuropsychology testing. And she also has a little child now, which she's taking care of. So that might also be a reason to be tired. Having 4 kids myself, I can assure you. Here's another case. This is not a tumor case. This is a case of epilepsy, a so-called transmental cortical dysplasia involving the entire left temporal lobe. And as you see here, fMRI showing function within the lesion, but the patient had very debilitating epilepsy. But we could remove the entire thing. And she's totally seizure-free. This was 8 years ago. She's still totally seizure-free. She initially had a little bit of a naming issue, not a significant decline after the surgery, but a decline whatsoever. And also subjectively, she felt that, but she has been recovering very well the last few years and still seizure-free. So this is the acute fasciculus in a specimen. You can see it here. And what I think is important with this image is that when you see the bend of the acute fasciculus between the frontal lobe and the temporal lobe, this is where the fibers are the most concentrated. And this is the most sensitive part in the entire brain for language. It's not Broca. Well, it's almost Wernicke, because this bend, this sort of bend of the curvation of the acute fascicle is under deep to the Wernicke area, but a little bit higher up, a little bit more cranial. But in this part where the bend is, it's very tightly concentrated white fibers in this motorway of language. What you see in the ends, in the other parts, in the ends of both the frontal and the temporal part, is that they spread out in the end of the fascicle, and this is what I showed you with the cities and the motorway. That the cities are spread out, but the motorway in the middle part of the fascicle, this goes for all fascicles, is very highly concentrated. So this is the most dangerous part of the entire language system to injure. You have to know how to test the acute fascicle to operate in this area. Some things here, I don't know. Okay, motor function is quite easily tested. We use monopolar pen. You can use a bipolar. The simplest way to do it, if your resources are somewhat limited, is to do what Mitch Berger does in San Francisco, and he's the most cited neurosurgeon ever. So what he does is, of course, correct. He uses a bipolar, and he just looks at the twitching of the patient's arm and leg. We use a little bit more sophisticated method where we have EMG electrodes in the muscles that we are interested in, and we have a neurophysiologist monitoring the entire time. We have a continuous MEP strip on the motor cortex, and then we also, of course, monitor the corticospinal tract subcortically in the white matter. And with this method, with this monopolar method, we can actually very well decide the distance to the motor tracts. So I can go down with this method to maybe 2 millimeters close to the corticospinal tract, because every milliampere that I stimulate with is equivalent to 1 millimeter in the tissue. So I can sort of tighter myself down to the cortical tract. So if I stimulate with 10 milliampere and I get a signal, but I don't get a signal with 8, I know it's between 10 and 8 millimeters left to the tract, and then I can go closer and closer. 15 years ago, I was younger and more bold, and I tried to go down to 1 millimeter, but I had 2 patients where I got permanent mild paresis, but still permanent paresis with that kind of margin. So I now I have in an awake patient maybe 3 millimeter to the corticospinal tract. I say a sleep patient, awake patient, because if I have to do it in an asleep patient, which is sometimes necessary if the patient cannot be awake, I have a little bit higher margins in a sleep patient, because I have the experience that the anesthesia medicine sort of numbs the white matter tracts a little bit. So I maybe 4 or 5 millimeters in 4 or 5 milliamperes in a sleep patient. For speech and language, we have a neuropsychologist. You can have a speech therapist, but we use a neuropsychologist. The patient sees a screen. You can use a paper system as well. We started with that 15 years ago, but the system we use, which we collaborate with Mayo Clinic, Florida, We can also get some research numbers, like how many accurate images I get, and also the latency in the answers. So the psychologists present these images to the patient, and the patient is supposed to read the sentence, very, very important for semantic function, and name the object. So this is an airplane, for instance. Not only airplane, this is an airplane, very important. And in our system, we get a sound if it's right or wrong for me to know, because we don't want to tell the patient that they are wrong or no or something like that. So we have different sounds for right and wrong. For perception, very important tract for perception is the right IFOF. The left parietal lobe is also involved. The salient network, I will not go into detail in the salient network, but it's a very important network to know if you're working a lot with this. And the precuneus is an important part of it. It's an important part of the salient network, but it's an important part of perception. So this is the areas involved in different, you see, perception deficits after surgery from one of these analyses I showed you before, a lesion analysis. For this, I will show you. Okay, we see more here. The right IFOF there, and from a publication here, you can see that this is where you can find. You can provoke neglect by stimulating in this area. We use this test called the line bisection. We have it in the software, but you can also use pen and paper if you have limited resources, and if you want to start up, you can just. So the patient is supposed to put the small a vertical line in the middle of the horizontal line. So these are all lines that the patient have a sort of put on the horizontal line. And if you can provoke neglect, if you are close to the right IFOF, for instance, the patient tends to deviate and end up in the end, one of the ends of the horizontal line, so they don't put the vertical line in the middle. And then you're close to the pathways involved in perception. Facial expressions. I had a patient, for instance, who was a bank director, lending money to people. He had to have the function of understanding the patient's facial expressions to see if he could trust them. And then you have to test that, and it's usually located cortically in the supramarginal gyrus. I am not so sure what white matter tracts are involved, probably SLF3, because that is closely related to the supramarginal gyrus. I haven't seen any studies on that. Maybe someone else has. This is the so-called reading the mind in the eyes test. We don't use this because we think it's too complicated it's too hard, actually. We've tried to do it ourselves. So we use a full face expression. And the patient has to say which one of these emotions are these eyes expressing, or in our case, the whole face. Practicalities. I've been very quick now, I think, but we have time for questions then. Some practicalities. This is our setup. This is the first patient I did in Örebro since I moved there. She's a medical student. She's of course consented to me showing the images. She was operated twice before in our department before I arrived for a low-grade glioma, which was progressing. And the first surgery, she got an SMA syndrome and actually not really recovered. And what we could see, I should have included those images, what we could see was it was an injury to the frontal ascending tract on the left side. And now it was growing, the tumor again. So, and the second time she was operated, they only removed 50% of the residual tumor. So now it was growing again, and we operated her awake, and we of course tested speech function. Tested the frontal ascending tract. Was hard because it was already injured, but we could at least test all the way down to the arcuate fasciculus, which through which we could actually make we could perform a radical surgery. And she was back in medical school in only 1 month. Actually, she's a little bit. I talked to her the other day. She's a little bit slower, she thinks, than she used to be, but we haven't detected any post-operative new deficits in the neuropsychology assessment. However, we have to say that she was very, very high performing in all the tests before the surgery, and she's still over average, above average, but maybe a little bit of a decline, but above average. This is a now famous picture in Sweden because the Minister of Health visited us, and we have this. This is the same patient. We have this on the wall of our department, and the minister thought it was such a nice picture, so she posted in front of this picture, and it was all over the internet, and that she had been visiting us, and so this is a patient. Of course, we call it "The Patient is in Focus" is the name of this picture. It was taken by the hospital photographer. So you see the patient there. She's looking at the screen. You see the back of the head of the neuropsychologist, and then you see me, the surgeon, behind that sheet there, the transparent sheet. So I do the stimulation there, and she looks at this. And it's the setup we have with this. I think translucent sheet is very good because I can see the neuropsychologist. We can have some communication. I don't have to go around and talk to the patient. We have a good connection with this kind of system, and it's also not very space consuming. The equipment we use is monopolar, of course, because we can do the tissue distances, but Dufour, for instance, he uses bipolar stimulation, so of course that's fully legible. You can use pen and paper. That's of course the cheapest way of doing the test. You can have papers with a sentence, "This is," and then an image. You can test that way. You can have pen and paper for line bisection, for instance. You can also use a simple PowerPoint. We think it's easiest if you have the possibility. The best system is double screen for the neuropsychologist to see the same images as the patient. And I will show you the software we use, where the interface of the patient and the psychologist are quite different. This is the software. This is David Sabsevich in Mayo Clinic, Florida, and we are the first center in the Nordic countries using this software. And as you can see, the psychology, the first screen you see closest to the image is what the patient sees. So it's only the presentation of the image. This is of course a visuospatial test, and then the psychologist sees the other screen with all the data on, and he gets also data live. What is the error rate? And he can do the test the day before with the patient and get an error rate, and then he gets another error rate during the surgery, and he can sort of evaluate how much decline the patient has when we stimulate or resect. I think the bare minimum to learn, if you're the tests you should know, you should master if you start, is the naming test. But you have to use the sentence. If you don't have the sentence, you test a very small part of the language system. But if you have the sentence and you make the patient say, "This is a house," for instance, then you test a much more complex more parts of the language system. So you can find the IFOF, you can find the ILF, you can find the arcuate fasciculus with this simple test. If you use a sentence, if you just use the images, you're only testing the dorsal stream. But if you want to test both the dorsal stream and the ventral stream, you need to have the sentence as well, because the task gets more complicated and it uses more parts of the system. And we also use the line bisection, as I said. I think, why are these the bare minimum? Because this is the first image. The naming test is testing huge parts of the left hemisphere in most patients, and the other one is testing big parts of the right hemisphere. So back to these questions. If you test too much, you will leave too much tumor. That has been proven wrong many times over and over again. It's actually the other way around. The centers that have the most complex testing usually have higher resection rates than centers doing more simple awake surgery or even sleep surgery. Why do awake craniotomy on the right side? Well, if you know, there is also function on the right side, so you have to test function in the right side as well. We don't only have one functioning brain hemisphere. And what white matter tracks should you know? I had a slide on that. Should high-grade gliomas be operated awake? Yes, if you have the resources, absolutely, you should do that. Much more important to use awake surgery than have navigation system for tumors. Much more important. How do you know that the tested function is related to postoperative deficit? This is Dufour uses a publication method where he first does a lesion study, one of these studies where he combines images of many patients and see where the hotspot is for the deficit, and then he tests that part with a test, and then he publishes a paper about, okay, this test actually finds this hotspot that we could show in the first study. So that's a way to find out. Awake surgery demand more resources. It does not actually. There have been studies now showing that it's cheaper. It's much more. It gives a patient. You have a patient that is feeling much better postoperatively. So our patients doing awake surgery usually leave the hospital in 2 or 3 days, whereas when we do a sleep surgery, they usually stay for 4 or 5 days. And this has also been proven in several studies showing that the hospital stay is much shorter with awake surgery. So the goals with testing, you can have different goals. It's different in different patients depending on what their profession is, of course, and what their cognitive function is before the surgery. I usually have this saying that you want the patient to be able to keep your job, keep your house, and keep your spouse. So keep your job, meaning that you should be able to keep doing what you do. Keep your house, meaning that you should be able to take care of daily business. And keep your spouse, not be too much change in personality after the surgery. So these are the aims with every surgery. And of course, what kind of function do you need for these things is different in every patient, depending on their profession and their cognitive abilities. So summary. Awake surgery improves survival, quality of life, and cost of care. It has shown us the importance of subcortical white matter tracts as opposed to the old way of thinking only of the cortex. We think of the cortex as well, but we're not so afraid of the cortex. We're more afraid of the white matter tracts. The cortex has a plasticity. It usually works out even when you resect parts of the cortex. But if you resect the white matter tracts, especially in the most concentrated parts, you will injure the patient permanently. There are standardized methods of intraoperative testing. There are a lot of good reviews on this. And that's all. Thank you very much.
Okay, thank you very much, Dr. Begram. It is so impressive, and you have so many informations. I learned a lot, and maybe different kind of question will come up. But this is kind of educational program, so I will start in the for the education wise. In that. You mentioned about high-grade glioma, awake surgery. Yes. I totally agree that I will do awake surgery, especially high-grade glioma, not only grade 3, but grade 4. However, we have to think about the indication of the patient. For grade 2, grade 3 glioma, patient usually do not have any language or aphasic problem. I'm mentioning about frontal or posterior language area. Okay, so it's awake for language. How do you figure out that you can pursue right awake surgery for the high-grade glioma in case the patient already have some aphasia? Do you do awake surgery for having aphasic symptom, or which level of the aphasia you choose awake surgery for high-grade glioma?
Yes, I usually do, and the problem sometimes might be that they are very cognitively affected, and that might be a problem with the communication during surgery. Mm-hmm. But if they have a mild or moderate aphasia, I still want to avoid to injure for instance, the arcuate fascicle to give them a total aphasia. So what we do practically is that we do testing the day before, and we remove all the images that they cannot name, and then we only use the images that they can name. And we go for. I actually had one of my residents with me for a case like this a few weeks ago, and I told him that the aim here is not to give the patient a total aphasia. So the first aim we have surgically is to identify the arcuate fascicle. When we found that, okay, we keep away from that, because then the patient will still have some communicational ability. So that is the aim for those patients. So that's the question, answer to the question, I think.
Okay, thank you very much. So in that case, how old can you try, especially for younger and also older? Well, younger generation, sometimes you have a problem during the awake surgery, like emotional incontinence or very drowsy, and also the high age elderly patient. They sometimes difficult to have. So you do awake, sleep awake sleep, right? Technique.
Yes.
In case.
Yes.
So what is limitation of the age? What do you think?
Yeah. I think it's more of a when it comes to younger patients is more. We are a little bit lucky that the most tumors are found when they're a little bit older, but like low grade gliomas. But I think the youngest patients I've done is 16, and so that has more to do with maturity than biological age. And the oldest patients I've done is 82. And that worked very well as well. But I think you are absolutely right that there are other things to consider as well when you get older. There are some comorbidities that might be complicating the anesthesia. You have to have a good airway, of course. So there are other things as well to take into consideration than only the cognitive considerations. But I think it's an individual thing. We've had patients that are in the perfect age, but most problems I've had are with patients that are a bit what do you call it in English? They have a forced personality, very high energy all the time. I had a boxer, for instance, that we could not wake him. We could not wake him up because he was almost boxing the anesthesiologist. He was so stressed during the surgery, so we had to put him to sleep again and do the surgery asleep. So I think it's more a personality trait, more an individual thing than an age problem, actually.
Okay, thank you. And also, let me confirm that you do awake surgery for motor area.
Yes.
You do. Yeah. Okay. I agree. Maybe there are issues that some say that you don't have to do awake surgery for motor area. Some say that I do awake surgery. So let me have your opinion.
Yes, that's an interesting way of putting it, because I think for me, if the patient can tolerate awake surgery, I see no reason to do it to sleep. There is no reason at all. There's no safety problem if you have a good anesthesia team. We had a case last week where we actually could not do it awake because he had a problem with the airway. They tried to wake him up with a laryngeal mask, but they couldn't get it tight. And then we said, maybe we can wake him up and do it all awake, which we did in the beginning 15 years ago. But then she said, I suspect there's something wrong with the airway. So she intubated him, and she saw in the video laryngoscope that he had a abnormal epiglottis. So there was a problem with the airway. So what was the question again? Sorry. Yeah, motor function. Yeah, motor function. My main message is that if you have a good team, if you do a lot of awake surgery, there is no problem doing it. So there is no reason to do it to sleep, really.
I see. And also, I heard that you do surgery not only in Sweden but also Abu Dhabi, in different language countries.
Yes.
Do you figure out the difference between each language, or like a first language, mother language, second language, third language? Maybe you have experience with having 2 or 3 language speaker. Is there any experience that you can share with us?
Yes, I was only there for a year, so I didn't do a lot of cases. I did about, I think, 15 cases, but it was very interesting. And my reflection when I was there was that there's a big span also in educational level in Abu Dhabi. There are a lot of guest workers with a low level of education, and also there are not only language differences, there are also cultural differences. Some words don't exist in some languages, and some concepts don't exist in some languages. So I had a patient from Bangladesh, for instance. He didn't know what a pyramid was. I had a pyramid. I had a pyramid in my slides, and it wasn't that he didn't know the word. He didn't know what it was. He'd never seen a pyramid. He'd never read about a pyramid. And so I had to remove that image, of course. But my practical view on doing it in a multi language environment is that if you boil it down to the bare minimum, you have the naming test, and you have the line bisection. It works for most patients in any language. I didn't have a neuropsychologist there, so I had nurses who were translating for me, and it actually worked very, very well, I have to say. I'm still in touch with some of these patients on WhatsApp, so it's a challenge, of course, but you have to boil it down to more basic testing. I think you cannot do the more advanced testing with association function and executive function. That will be too hard if you don't master the language yourself. Our professor here, for instance, he's from Hungary, and he did awake surgery in Hungary. Andras Büki, he's most famous for trauma research, but he did awake surgery in Hungary. He said, I will not do it in Sweden, because if we're doing more advanced testing, there's a language barrier for me, he said, for Swedish. So I think when you do the basics, it works well, but if you try to do more advanced testing, it's a bit harder in the second language, both for the surgeon, psychologist, and the patient.
Okay, thank you very much. Okay, is there any questions and also opinions from the audience?
Yes, there are. We'll first take it from the chat box. Is Dr. Harshad Parekh is asking the questions. If you can see the chat box, Prof. Vigran.
Yes, there's 3 questions from the same colleague. And the first question is, awake surgery, when do you stop resection? Well, I never go into the more concentrated parts of the fascicles in any patient, in any fascicle, but of course it's a little bit depending on the needs of the patient for cognitive function. If it's a lawyer, I will be very careful with the language. I will not affect the language at all. If it's a carpenter, of course, motor function is very important. So I tailor the resection a little bit regarding what patient I have on the table. And this is the philosophy of we are a few people in the world, a lot of people in the world in this kind of philosophy, but I think most influential, of course, has been Professor Dufour, talking about this a lot around the world. And then we have the other question, how you manage convulsions. We give levetiracetam. We used to give phosphenitrine. I haven't seen any problems with any of these. I gave I gave equivalent dose as I would give to a patient with a status epilepticus, so it's quite a high dose, and the problem might be with phosphenitrine that you have blood pressure problems. So levetiracetam, I think, is easier. So I usually give it around either 1,000 or 1,500 milligrams. And if we get a convulsion during surgery, the classical way of handling that is with ice cold water. So you have a bowl with ice in it, and you have a big syringe with sodium chloride solution, and you just rinse the brain with that, and it always calms down. I've never had any problems with that. It always works. I had in the beginning, I think in 2007, I think, 2008 or 9, we had a generalized, very, very tough seizure on one patient, but then I had to put my hand on the brain to keep it in the skull, and then we rinsed it under my hand with a. So that's the most dramatic we've had. But since then, I haven't had any more than focal seizures, actually. And the last question is if we do it for corpus callosum tumors. I have not actually, but I see no reason not to. If it's and when I think about it, maybe you could do. I haven't done it, but callosotomy for epilepsy would be interesting to do awake as well, because you sometimes get some severe cognitive problems. But I haven't done it practically. But there is no reason not to.
Okay, thank you.
There's
Thank
been
you
a
very
discussion
much.
the last few years about
Okay.
tumors close to the corpus callosum.
Okay, we'll take questions from the audiences, starting with
Yeah.
my co-host, Dr. Libun Singh.
Yeah, thanks, Raja. Thanks, Prof. Yeah, for very comprehensive talk. I have two questions, Prof. One is regarding the reliability of testing of speech and languages in awake surgery. And now we do have a new neuromonitoring cortical evoked potential. May I know, in your opinion, whether this would replace awake craniotomy or would make awake craniotomy more reliable in the testing? My second question regarding preservation of languages. Many times we heard from Professor Dufau, patient was given only 3 languages to be preserved. Is it really true due to the limitation of time during testing, or is something that figure 3 is obsolete number? Thank you, Professor.
Thank you. I don't think it will. For the first question, I don't think it will replace awake surgery. I think it will be. I haven't used the method myself. We have been discussing that the last few months to introduce that method, the cortical potentials, but I haven't used it. I think it will be a good complement to the a good addition to the arsenal we have. I don't think it will replace awake surgery. I think there is it's a very, very long road to replace awake surgery, I think, with other methods. And I have a hard time finding any reasons, actually. But there are a few patients where you cannot do awake, and these methods are very helpful. And the second question, can you repeat? Sorry, Professor, repeat the question.
Preservation, only 3 languages. Is it true, absolutely true, or by Professor Dufau? He always tells us that the patient can only limit to 3 languages.
I've never. I have heard him say that as well. I've never reflected on it, actually. I think it's an old misconception that different languages are sort of located differently in the brain. I don't believe really in that. There is some interesting research, both Japan and China, I've seen on this topic, but I think they share the same white matter tracts. So if you injure the white matter tracts, the most research are on the cortical function. So if they still share the same white matter tracts. My experience, not scientifically, but my clinical experience, is that multi-language patients usually have more widespread language function in the brain. They use more of the brain for language, which means they are less vulnerable when we do the surgery. They have more resources for plasticity. They have more complex language systems, which also, I have to say, is true for women versus men on a group level. There's huge individual variation. You always have to add that, but on a group level, my experience, and there's also been shown in fMRI studies, is that women have more widespread language function than men. We also see this in stroke, where in more men you get a total aphasia with a MCA infarction on the left side, and in more women you have better plasticity after that and better recovery. So I think multilingual patients have better resources for plasticity.
Thank you, Professor.
That was a political answer. I didn't answer the question really. I just said something else, but a reflection on the question.
All right. Thank you. Yes, Dr. Madonna.
Thank you. Thank you, Professor. First of all, I'd like to express my gratitude for a spectacular lecture. I'm a youngest neurosurgeon, female board-certified neurosurgeon in my country. I come from Georgia. most of the questions you answered throughout the lecture, but I still have one question. Like, you mentioned that your resident assisted you during the surgery. So I had only one case of awake surgery during my residency, and in my practice, I haven't performed any. So is it the part of the residency program in your country? And if it is, what is the learning curve for young neurosurgeons such as myself? And the second question I have regarding to the how frequently do you have to convert to the general anesthesia, and what are the major causes? Like, is it anesthesia related, airway related, and for what is the, or something else? Thank you.
For the first question, I think it should be a part of the training for a resident to be part of awake surgery. I think it's very, very important because you need to understand the three-dimensional anatomy of the pathway system. You should also take part of cadaver dissections, white matter cadaver dissections. I think that's also very, very helpful for learning the anatomy. And you should do that with a neurosurgeon and not with an anatomist, because you should discuss what will happen if it's also important for me to do that. I've done that a lot. I'm teaching anatomy on medical school, and what we do there is that we do white matter tract dissections. We don't do the slices anymore. We do three-dimensional white matter tract dissections, and we combine that with discussing case studies on what will happen with the lesion here and the lesion there. So I think it's a very important part of the training. Of course, I don't let the resident resect the most junior resident. Let them resect the most sensitive part close to the white matter tracts, but they can start doing some cortical testing, and then they can do some testing just to get the feel of the anatomy. Professor Dufour doesn't do that very much. He does the entire surgery himself. But I think for me it's important to teach residents functional neural anatomy, both by dissections and surgery. The learning curve is quite long because you need to both understand all this theoretically, and you need to understand the three-dimensional anatomy of the tracts, how they pass through the insula and so on. So it's quite a long learning curve. I've just started training the one who will succeed me at one day. He's quite a young consultant. I've told him that I expect you to be able to do this completely by yourself, maybe in 5 years. So 5 years after board exam, I hope he can take over and I can do something else, help him in the more complex cases. But I think it's important to be acquainted with this. And your second question, sorry.
About how often do you have to convert to general anesthesia, and what are the common reasons for that?
Yes, very rarely actually. I always say that we use the sleep-awake-sleep method, but more commonly we use the sleep-awake method because we have the team is so well trained, so we are quite fast. So usually the patient can tolerate for us to close the case with the patient awake. So we don't have to convert even to close a patient. And the only conversions I've had, unplanned conversions, is the most common reason is that the patient gets too tired, and the anesthesiologist get a little bit worried about the airway because the patient is tired. I've done around 300 awake craniotomies, and a couple of them we have been very obese. And that is a problem sometimes because that then they they get hypercapnia, and of course the brain is swelling because of that. There has been some case of that, maybe one or two throughout the years. Otherwise, it's been patients that hasn't really waken up. When you try to wake them up, they don't really wake up because we have had discussion about, there are some studies about cortical inhibition, that you can get cortical inhibition by touching the brain, which is the same thing that you get from migraine, actually. Spreading depression, it's called. Cortical inhibition, spreading depression. You can have that, and then the patient does not awake. And I've had some of these with forced personality, and maybe the thing that sort of made them more forced was the steroids. So I've had a couple of patients, but with between 300 and 350 patients, we have converted a handful of times unplanned. Very few times. Never because of seizures. that has always been possible to solve.
Thank you. Thank you
Thank
very
you very
much.
much
We
for
had a
this.
wonderful discussion. If there are no further questions, Professor Takashi Kon has joined us from Tokyo. Any questions? Just
Yeah.
quick one.
Yeah, thank you. I'm Dr. Takashi Kon from Showa University, Tokyo, Japan. Yeah, thank you for a nice presentation. I would like to about our surgery of multilingual patients. So Swedish or EU or English, so English-speaking patients. So language type is similar to EU language and English, but in Bengali or some Arabic, so and Japanese and English, so different types of language systems other than mother tongue. So if you have the experience of multilingual patients in the Bengali or Asian countries or the Arabic countries, so are there any difference between the after surgery influences after surgery? Same surgery and after recovery, or some other difference?
This is actually an extremely interesting question because there are some studies. I don't remember the name of the researcher. I think it's a Chinese researcher. I don't. Sorry for forgetting the name, but he did some very interesting studies on picture-based language systems and letter-based language systems, that they are differently distributed in the brain, which I think is very interesting. So some languages are probably more picture-based and therefore more visuospatial, more right-sided. So the normative brain, the Western brain that has been used for research classically, maybe is not the most common in the world, actually. So there is interesting aspects on that picture-based languages might have more widespread language function in the brain than letter-based language functions. However, in practice, when I do the surgery in patients with other languages, I have not changed anything really. I have done it the same way. It has worked the same way because it's quite basic, the testing. It tests, and if you just tested the white matter tracts, if you focus on the white matter tracts, you get so severe effects of the stimulation. So I think it will affect any kind of language. But on a theoretical level, I think this is a great area for research to see if there are more differences that have already been described when it comes to picture-based and letter-based languages.
Yes, I understand. Thank you. So I expect your further research and further results. So I'm very interested. Thank you.
Yes.
Thank you very much. We had a wonderful session and very interesting aspects of awake gliomas surgery. Thank you very much, Prof. Patrick Wigren.
Thank you. Thank you very much.
Thank you very much, Prof. Maruyama. We are extremely grateful you chaired for us today. Thank you very much. So we'll move on to the second session, and I will hand this podium over to our Honorable Chair, Prof. Fuminari Komatsu, to say a short introduction and invite Prof. Amador for his lecture. Prof. Komatsu.
Thank you, Dr. Raja. I'm Dr. Komatsu from Fujita Health University, Nagoya, Japan. Thank you for giving this opportunity from Dr. Raja and Professor Yoko Kato. It's my great pleasure to be our chair of this ACNS seminar today. So the second speaker today is Professor Joan Luis Gomez Amado from Mexico. He is a professor and chairman, Division of the Neurosurgery, National Institute of Neurology and Neurosurgery, Mexico, and also the president of the Mexican Board of the Neurological Surgery. So today's his topic is endoscopic techniques applied to vascular neurosurgery. I'm looking forward to hearing your great presentation, Professor Dr. Amado. Please start your presentation.
In the first place, I want to thank the excellent and enlightening lecture of Professor Wigren, and I would like to thank the ACNS for this kind invitation to talk to you about some endoscopic techniques applied to neurovascular pathology. Thank you, Professor Raja, and thank you, Professor Komatsu. We can have three possible scenarios in which we can use the endoscope as a tool for visualization in some neurovascular pathology. The first one should be the endoscope-assisted microneurosurgery that we can use to treat some intrinsic or extrinsic tumors, as well as some intraventricular lesions, but also some aneurysms. The second clinical scenario is the use of endoscopic port surgery. We can use this to treat intrinsic tumors, metastases, intraventricular lesions, but also for aneurysms and cavernoma. And the third one is the endoscopic endonasal surgery, which is a little bit controversial to be used in neurovascular pathology, but we can use mainly for pituitary adenomas, chordoma, cranopharyngioma, meningioma, etc., but also for some aneurysm cases and cavernoma in very well-selected patients. It is important to address that the basic principle of all these procedures is microneurosurgery, and Professor Jasha Hill gave us the tools in which we can use tridimensional anatomical knowledge, the stereoscopic vision, which is transferred to proprioception when we are using endoscopic techniques for these cases, but we must apply common sense, and also we have to have the courage to perform the necessary maneuvers to resolve the patient's problem. We know that for the treatment of intracranial aneurysms, we have to have a full exposure of the anatomical surroundings of the lesion so we can perform precise occlusion of an intracranial aneurysm. And for some other cases, it is not possible to perform the proper reconstruction, so we need to take advantage of some other techniques such as the aneurysmectomy and the bypass technique, as we can see here in a very large MCA aneurysm, in which we are exposing the lesion, and after careful dissection around the aneurysm, we decide to take off the aneurysm out in order to have a proper visualization of the perianeurysmatic anatomy. In this case, we open the sac, and after opening the sac, we take out the aneurysm and we perform the bypass technique to have an adequate reconstruction of the middle cerebral artery bifurcation. We perform two anastomosis in this case, and we have an adequate exposure of the vessels and a proper reconstruction, as you can see here, with the fluorescein and the indocyanine green in this particular case. So these are the spectrum of the techniques that we can use when we are treating a patient with an intracranial aneurysm. It is important to have a proper training, and today it is very important that we learn these techniques in the laboratory. We can learn how to harvest the donor vessel, for example, in the cases of bypass. We need to learn how to use regular techniques, skull-based techniques, and the appliance also of endoscopic techniques to become familiar with what the patient needs in some instances. So for the first case with the endoscope-assisted microneurosurgery, there is a protocol that we follow at the National Institute of Neurology and Neurosurgery in Mexico. So it allows us to have an integral visualization of the perianeurysmatic anatomy under direct vision. So the steps that we follow is preclipping endoscopic exploration after careful dissection of the perianeurysmatic anatomy. Then we go to dissect the aneurysmatic complex, and then we clip the aneurysm. And we can clip the aneurysm in two fashions: directly with the microscope, or also having an endoscopic assistance for the clipping. In that way, we can have the visualization and the screen of the endoscope, but also the visualization with the microscopic view. And if it is necessary, we can perform the recollocation of the clip in the case of occlusion of a vessel. And after that, we perform a post-clipping endoscopic exploration. To do that, it is important to know that the endoscope that is better for this case is the angle endoscope, because this configuration allows the surgeon to work with ergonomy in the surgical field. In that way, the head of the endoscope is away from the hands of the neurosurgeon, so it is easy to have the necessary movements in the surgical field. We can use the 0 degrees endoscope, and in most of the cases, we use the 30-degree endoscope to have the proper visualization. We can use also 70 degrees, 120, etc. But in our experience, we have seen that with the 0 degrees and 30 degrees is enough, but always using the angle endoscope to have the head of the endoscope away from the surgical field. This is a case for a patient who had a ruptured anterior communicating artery aneurysm and right internal carotid PCOM aneurysm and a left internal carotid bleb. So we perform a right orbitocranial transclinoidal approach in this pregnant woman of 32 years old, and we can perform the aneurysm clipping under microscopic vision. We need to verify the adequate clipping of the aneurysm. And in this case, for example, we are treating the anterior communicating artery aneurysm, and for some reason, we perform the occlusion of the contralateral A2 segment. So with the endoscope, we were able to identify this condition. So we decide to reapply the clip in order to have a proper visualization. So in this way, we move the endoscope as if we are working in an anterior approach. We perform the clipping, and we have a proper visualization of both A2 segments of the aneurysm. Then we went to the contralateral bleb of the internal carotid artery, in which we put just a small piece of a sponge, and then we came back to treat the ipsilateral aneurysm. To do this exploration, it is important to know that we need to insert the endoscope to the surgical field under microscopic vision, because otherwise we will produce some damage in the surrounding neural tissue. In this case, the posterior communicating artery aneurysm, we can see an ear duct of the aneurysm behind the blades of the clip. So we decide to reapply the clip to treat this small ear duct remnant of the aneurysm, and in that way, we achieve the complete occlusion of the aneurysm with a curved mini clip in this case. And we have the visualization of the origin of the PCOM and the complete occlusion of the aneurysm. In this other case, this is a patient with bilateral MCA aneurysms, in which we use a left pterional approach, and we need to achieve the complete geometrical reconstruction of the M1 segment of the right MCA. So for that, we perform the left pterional approach, a wide dissection of the basal cisterns, and we went to the contralateral side to achieve the complete reconstruction of the M1 segment. So we use a fenestrated straight clip, occlusion of the aneurysm, the permeability of the M1, but also of this early temporal branch with no occlusion of perianeurysmatic anatomy. So it is important that in this case, although we are using the microscope, the endoscope view is fantastic because we can perceive all the anatomical branches that are surrounding the aneurysm with complete occlusion of the case. This is another case, multiple intracranial aneurysms. We performed a right pterional approach. We took off the anterior clinoid process with a wide dissection of the skull base. We came to the basal cisterns, identifying the optic apparatus, dissecting the contralateral sylvian fissure, and then we were able to perform with the microscope the direct clipping of this contralateral MCA aneurysm, and then we take the endoscope so we can visualize properly that the anatomy is preserving the contralateral MCA. Then we came back to the anterior communicating artery aneurysm. We perform all the occlusion with the microscope, then we insert the endoscope to achieve adequate reconstruction. And finally, we came back to the ipsilateral aneurysms to perform the occlusion under the microscope. This is another case, a patient with bilateral PCOM intracranial aneurysms, a male of 65 years old with subarachnoid hemorrhage, contagious 2, fissure 2. We perform a left orbitocranial approach, and after careful dissection of the basal cisterns, we were able to identify the contralateral aneurysm, perform the clipping under the vision of the microscope, coming back to treat the ipsilateral aneurysm, and then insert the endoscope to achieve the proper visualization of the blades of the both clips. And in the postoperative angiogram, we can see complete exclusion of both aneurysms using a unilateral approach for these bilateral internal carotid artery PCOM aneurysms. This is another case, It's a patient that we took to the hybrid OR using the road mapping guided clipping technique for this basilar aneurysm. And then we performed the intraoperative angiogram, getting the information necessary to treat this case. This was a very medium size aneurysm with a compression of the third cranial nerve. After performing the initial study, we did a pterional standard approach. We took the anterior clinoid to gain access to the lateral aspect of the interpeduncular cistern. We opened the dura mater, and after careful dissection of the basal cisterns, we tried to reach to the region of the interpeduncular fossa using Transylvian standard approach. We can see the vessels on the bottom, but the visualization that we will have using the endoscope gives us the proper tridimensional understanding of this suprabasilar aneurysm. You can see the perforators on the top of the basilar artery, the origin of the posterior cerebral artery, and the superior cerebellar artery on the left side. So after performing the necessary maneuvers to achieve the complete occlusion of the aneurysm, we will see that it was necessary to use 2 clips, and after that, taking out the aneurysm to relieve the pressure over the third cranial nerve. The standard dissection is guided with this road mapping technique that we use to see the clipping in real time in the view of the angiogram. And after careful dissection, we will identify that there was a small remnant portion. So we reapplied the initial clip, and then we took off the aneurysm and coagulating the corpus of the aneurysm. Again, with the guidance of the road mapping technique, we apply a second mini clip to achieve complete occlusion of the aneurysmal sac and preserving at the same time the perianeurysmatic vessels, as you can see here with the microscopic view. Then we can insert the endoscope, as you can see here, under guidance of the microscope, and then we can have a close and different angle vision with the endoscope that we achieve using this inspection tool to guarantee the proper occlusion of the aneurysm, the region of the superior cerebellar artery, the coagulated corpus of the aneurysm, and the interpretive post-procedure angiogram showing complete exclusion of the aneurysm. So I can say from our experience that the endoscope-assisted microneurosurgery is very useful when we are treating bilateral multiple aneurysms in which we can assess the proper occlusion of the sac of the aneurysm. For some internal carotid artery PCOM aneurysms, it is quite interesting that we can see properly the origin of the PCOM and assessing the complete occlusion of the aneurysm. For some basilar aneurysm cases in which the corridor could be a little bit narrow in some instances, the endoscope gives us the proper visualization to achieve complete occlusion of the aneurysm. The second clinical scenario in which we can use endoscopic technique is endoscopic port surgery. And in this case, we were using this technique since 2009, and in 2024, we introduced this particular useful endoscopic ports designed by Minka Sam. And in that way, we can use the microscope or the endoscope to treat these lesions. We can have a holder to hold the endoscope, or we can use the endoscope free hands to perform the procedure. This is important to address, as Dr. Bigren said before. We have to have a proper understanding of a tridimensional anatomy, and this is the best way to preserve the anatomy surrounding a lesion. For that reason, the fiber dissection technique that I learned from Professor Touré, we teach to Professor Kadri, it is important to have this training to understand the tridimensionality of the central nervous system. We have used this technique to treat some intrinsic lesions but also some extrinsic lesions that invade the ventricular system, as in some cases for giant pituitary adenomas. This is a case in which we use endoscopic port technique for cavernoma surgery, a patient of 42 years old with headache, seizures, and he presented with this lesion in the right frontal lobe. So we insert the endoport under navigation guidance, and after the port is inserted, displacing the white matter fibers around it, we can perform the precise lesionectomy of this lesion using both hands with standard instruments that we introduce through the endoscopic port to achieve the complete resection of the lesion. In this technique, we are practically using microneurosurgery with the visualization of the endoscope through an endoscopic port to have a proper exposure of the lesion. The advantage of using the endoscopic port is that we can angle the endoscopic port so we can reach the lateral portions of the lesion, and after complete excision, we perform adequate hemostasis. And as you can see here, in the immediate postoperative MRI, we can see the trajectory that we follow to take out all the lesion in this patient. This is another case, patient with a left temporal hemorrhage, a male of 32 years old who presented with a headache with a temporal cavernoma. After insertion of the endoscopic port, we drain the hemorrhagic component of the lesion, and after that, we can perform precise lesionectomy of the active portion of the cavernoma so we can avoid a future hemorrhagic event in this patient. The dissection is performed using both hands. We can clean perfectly the surgical field, perform adequate hemostasis with the standard instruments, and after careful analysis, we take the last portion of the lesion, and then when we take out the endoscopic port, it is important to see if there is no bleeding in the surgical corridor that we are doing after taking out the port. You can see the complete exclusion of the lesion using this small approach. This is another case, a very particular case, in which the endoscopic port technique was used to treat this patient with a distal PCA aneurysm who presented to us with a parenchymal hemorrhage and intraventricular eruption of the hematoma. So what to do in this case? We said, okay, we have a large hematoma that is giving us the pathway to reach the aneurysm. So we insert the endoport. We were able to dissect the aneurysm, perform the adequate clipping, and the exclusion of the aneurysm, as you can see here, using this endoport technique. I think that for some deep-seated lesions, using navigation or some intraventricular lesions, this technique is really very ergonomic to perform the procedure without damaging the surrounding brain. Also, for some hemorrhagic stroke patients, we can use this technique also by allowing us to have a precise directed trajectory and preserving the pathway using the endoscopic port to treat these lesions. Then we go to the most controversial part of the endoscopic use for neurovascular pathology, which is the endoscopic endonasal surgery. We know that there are some complexities and different levels of difficulty when we are treating the lesion using the endoscopic endonasal technique. The most common technique that we use is that one that we use for to treat pituitary adenomas, that in our experiences is about 80% of the cases that we treat with endoscopic endonasal techniques. But we can go to other places, such as anterior fossa, to treat the neuroblastoma, meningioma, the orbit, the maxillary sinus, and intipeduncular fossa. For some cases of craniopharyngioma or pituitary adenoma, we can treat lesions in the cavernous sinus, such as pituitary adenomas, meningiomas, hemangiomas. But also we can use this technique to treat some vascular lesions in the subarachnoid space in the interpeduncular, prepontine, and prevulvar sisters. and also for some intrinsic lesions, such as cavernoma, metastasis, or glioma, that go from the area of the ventral brainstem. There are complications when we are using endoscopic endonasal techniques. Could be an arterial bleeding in 0.5% of our cases, but the most feared complication is the CSF fistula. In these cases, when we perform extended approaches, our CSF fistula rate is around 5%, and for conventional cases, no more than 3% of the cases. We can use different techniques as the nasoseptal flap. We can use the multi-layer reconstruction technique, in which we use dural substitute to occlude the cisterns, and then we put some fascia lata and a piece of bone that we got from the posterior nasal septum, and in front of all of these, we put the nasoseptal flap that we harvest at the beginning of a surgery. For some cases, we can use also pericranial flaps that we insert through a keyhole in the glabella, and for some cases in the anterior cranial fossa and some transcranial approaches, we use also an autologous fat graft to occlude the defect, and in that way avoiding the CSF fistula. It is important that when we perform these approaches, we should have navigation for some selected cases, intraoperative monitoring when we are treating lesions in the cavernous sinus, or also the mid-clival approaches, particularly for the sixth cranial nerve. We can use the Doppler ultrasound to address the position of the internal carotid artery. And also, for some cases, we use usually the visualization with 0-degree endoscope, but for some cases, we can use also the 30-degree visualization to address lesions lateral in the lateral parts of the exposure, such as a cavernous sinus or some lesions that invade the cisternal pathways, such as a craniopharyngioma, pituitary adenoma, or some vascular lesions. We have learned that we need to use always natural corridors to treat a lesion, as Yashagi teach us. For example, in the first case, we have a large cavernoma located in the thalamomesencephalic area. In this case, we use the left diurnal transivial approach using a transinsular transcorridal fissure approach to take out the lesion out. I have learned now that Professor Touré will have used a supracerebellar transtentorial approach to treat this lesion. But anyway, we are using natural corridors. For the second case, we use a left occipital posterior interhemispheric paraspinal approach and take out this large lesion located in the posterior thalamus. But also, for example, for this patient with a very large pontine cavernoma, we use the standard superior, median, suboccipital, and supracerebellar approach. In all these cases, we always use the natural corridor that provides us direct access to the lesion so we can preserve the surrounding neurovascular structures. After careful analysis of the anatomy, we have learned that we can reach the ventral surface of the brainstem using endoscopic endonasal transclival techniques. This is the MRI of a patient with a large lesion located in the ventral pons, and after careful analysis of the anatomy using tractography, we decide that it was better to use this endoscopic endonasal technique to treat this patient. This was a male of 29 years old who presented hemiplegic with several cranial nerve dysfunctions. So we decided to put the patient on tracheostomy and gastrostomy and have a heavy nutrition for 3 weeks. And as you can see here, the lesion is located in the ventral surface of the pons. The long fiber tracts are displaced around the lesion. So we decided to use endoscopic endonasal approach. What we did, after a careful exposure using a transclival approach, we reach the lesion lateral to the basilar artery. We decompress the associated hematoma, and we take off also the active portion of the cavernoma. In the postoperative MRI, you can see precise lesionectomy and the reconstruction on the transclival approach with adequate result for these patients. This is another patient in which we use the endoscopic endonasal transclival approach to treat a lesion in the ventral pons in this woman of 27 years old who presented with acute headache, left hemiparesis, and left hemianesthesia. After careful exposure of the mid-clival region, we perform hemostasis of the basilar plexus using a bipolar coagulation or some surgical foam, exposure the pons, the mid-basilar, and after identifying the entry point, we go directly to the lesion with the compressed hematoma, and as in the previous cases, we are able to dissect and taking out the active portion of the cavernoma. After we can perform a careful inspection of the surgical field and performing the adequate hemostasis in this patient. After this, we need to perform an adequate and proper multi-layer reconstruction technique to avoid the presence of the CSF fistula. There are some reports in the literature in which they were using this approach to treat these lesions, and the most frequent complication is the CSF fistula for these cases. This is the patient in the fifth postoperative day, in the bottom after 2 months, and you can see here the preoperative and postoperative MRI showing complete lesionectomy of the lesion using a very straightforward approach for this very particular case. Not all the patients that present with intrinsic brainstem cavernomas or tumoral lesions are susceptible to be treated using the endoscopic endonasal technique. What we have learned from the endoscopic endonasal techniques is that we can have a proper visualization of the arteries, the anterior and posterior circulation. And there are some reports in the literature since 2007 with Kitano, Herman Walla, Sebastian Fröhlich in France, and also Professor Kazan, Brazil, and Professor Enseñat in Barcelona, using endoscopic endonasal techniques to treat some vascular lesions. And in that way, we have also some experience treating lesions in this vascular area using adequate clinical judgment when it's necessary, and when we can offer the patient a better outcome using endoscopic endonasal rather than a regular standard technique. There are a few cases in the literature, reported no more than 40 cases worldwide, in which the most important series are from Professor Garner and Professor Hahn in Asia. So in most of the cases, the clinical presentation is with subarachnoid hemorrhage, and most of the cases are treated in the posterior circulation. There are some reports treating aneurysm in the anterior communicating artery complex as a primary approach or as a finding after taking out a tumor. So they identify an aneurysm and they decide to treat the aneurysm in the same surgical setting. But what we have seen is that the successful clipping in these cases achieves only 86% of the cases. There are 26% of complications, almost 20% of CSF fistula, and ischemic events in 15%. If we see these figures, it will be prohibitive to use endoscopic endonasal techniques to treat these lesions. For example, in the case of anterior communicating artery or internal carotid artery in the ophthalmic segment, there are described the transplanum and transtubercular approaches. Particularly, in my point of view, these aneurysms can be treated very easily using the standard or extended pterional approach, or even some skull-based techniques for very specific cases. But in the case for internal carotid artery in the medial paraclinoid area, the endoscopic endonasal approach gives us the perfect view of the medial wall of an internal carotid artery without disturbing the optic apparatus above. So this could be a very good indication to use endoscopic endonasal techniques. For the posterior circulation, the basilar tip can be treated using standard pterional or subtemporal or combined approaches to reach the interpeduncular fossa. But for some cases in the mid-basilar or the vertebrovascular junction, the endoscopic endonasal technique give us a direct visualization of the vessel without disturbing any cranial nerve and only taking out the mid and inferior parts of the clivus to have an adequate visualization. In that case, we have this patient, a very young patient, who was treated with endovascular therapy using 48 coils and 3 stents to treat this mid-basilar giant aneurysm. After some time, the patient developed intra-aneurysmatic thrombus that was compressing the brainstem. So we decided to take this patient to the meeting of neurovascular, and we say, okay, we can wait, the patient is stable, but after some years, the patient presented with quadriparesis and dysfunction of multiple cranial nerves secondary to the very large thrombosis inside the aneurysm. So we take the patient to the OR under neural navigation. We perform a wide exposure of the inferior part of the superior clivus, all the middle clivus and the inferior clivus. We expose the dura mater. We open the aneurysmatic sac. With the ultrasonic aspiration, we took off all the thrombus inside the aneurysm until we reach the area of the coils. And after that, with adequate visualization and the compression of the sac, we occlude the aneurysmatic sac with a good result for this patient. We can go also to the hybrid OR, as we show in the case of the basilar aneurysm using the endoscope as a tool. And in that way, we work from the chest to the patient up, and the endovascular team works from the chest down. We introduce the microscope and the necessary surgical tools to perform the procedure in the hybrid OR. We use this technique to treat this thrombosed vertebrovascular aneurysm who was treated before with the placement of stents, and we use endoscopic inferior transclavial approach in order to perform intraneurysmal thrombectomy in the hybrid OR under guidance of navigation and endoscopy. So this case, we use a wide exposure of the clivus, wide opening of the dura mater, identifying the aneurysmatic sac and also the parentium vessel. We perform the opening of the aneurysmatic sac. We took off all the thrombus that were compressing the brainstem, and after that, occlusion of the sac as we see before. In this particular case, we were able to use the rod mapping guided dissection technique, in which we use a shot of rod mapping, and after that, we are able to perform the necessary maneuvers with a complete visualization from the angiogram as we are walking around the area. In this particular case, also we use it in intraoperative Dyna-CT to see the complete resolution of the compression of the aneurysmatic sac over the brainstem. Finally, we can use these endoscopic endonasal techniques to treat some aneurysms located in the medial wall of the internal carotid artery in the paraclinoid area. We use a 3D angiogram, and for these cases, we can use a proximal control using a balloon with the help of the endovascular team. We can use the rod mapping clipping technique, and after the procedure, we can have the 3D angiogram in the same moment. So for this case, we use a proximal control with the balloon, direct visualization of the aneurysmatic sac under the optic nerve. We perform the careful dissection of the aneurysm. This is the pituitary gland in the inferior part. And after this exposure, we insert the blades of the clip in a straight fashion using a rod mapping guidance to achieve complete occlusion of the aneurysm. And after taking out the clip, we perform the intraoperative angiogram with complete exclusion of the aneurysm. I think that the endoscopic endonasal surgery can give us a great advantage for very selected ventral brainstem cavernomas, for mid-basilar aneurysms, aneurysms located in the vertebrovascular junction, and some internal carotid artery medial paraclinoid aneurysms. For the cases of anterior communicating or the cases of superior paraclinoid or ophthalmic aneurysms, I think the standard techniques are way better superior than the endoscopic endonasal, but are also reported in the literature. Finally, I think the laboratory training should be a very important tool to have the knowledge of the techniques, to practice the techniques before going to the OR. The tactile perception gives us, through the proprioception, when we are using two instruments in the surgical field, the supplementation of the lack of the stereoscopic view that we have with the axial view of the microscope. The treatment of these aneurysms require a very wide experience in microvascular neurosurgery, experience in endoscopic techniques, but the most important thing is to use a precise clinical judgment. When is the patient going to be susceptible to have these techniques? And the benefit for the patient should be the most important thing when we are using this clinical judgment to choose the adequate approach. For some cases, the hybrid OR suite allows an integral treatment because we can see the vasculature in the real time and we can use the road mapping guidance technique. For the treatment of ventral pontine lesions, it should be reserved for very selected cases in which this is the only approach that avoids damaging the surrounding brainstem tissue as well as the cranial nerves that cross in the surrounding parts. Thank you very much. I will remain aware for some questions.
It was so impressive for me. You presented the endoscopic assisted surgery and the endoscopic port surgery and the endonasal surgery as well. So I have some question for you. So there are many styles for endoscopic surgery, and in our country, Japan, the endoscope is mainly held by the endoscopic arm, a pneumatic arm, but probably the situation is different in each countries. I think so how, for example, in your country, who hold probably the assistant hold the endoscope, right? Mainly assistant hold the endoscope, and sometimes a surgeon hold the endoscope for observation or something. Please give us some comment.
Yes. For the cases of microsurgical assisted with the endoscope, I insert the endoscope by myself using the guidance of the microscopic view, but I hold the endoscope all the time. And for some very brief periods of time, my assistant can hold the endoscope after I insert it with the microscopic view. In the case for endoscopic port, we can use the holder to have a free hands surgery. But for some cases, when we are working in the deep portion, or when we want to have a zoom with the endoscope, then the assistant holds the endoscope. For the endoscopic endonasal technique, we have always used two surgeons in the operating room. So one surgeon performs the precise maneuvers, the dissections, and the other surgeon holds the endoscope. This is a very dynamic way in which we avoid to have spots of blood in the endoscope by moving the endoscope, and the endoscope can go around us. It is very important to have a team, so the assistant or the other neurosurgeon have the proper knowledge of what we are doing, so he can understand when to move the endoscope up, down, or lateral, when to take the endoscope out to clean the lens, and then to insert it again.
Thank you. And also in the port surgery, the port itself must be fixed by something, and the assistant hold the port as well.
Yes, we can use both systems. We can put the Lila retractor, so we take the lateral portion of the port, so the port is fixed all the time. And we can also use the assistant to perform the angles of the endoscopic port when it's needed. So, for example, when we are finishing the central portion of the dissection, then we move the endoscopic port to treat the superior, inferior, or lateral portions of the lesions as we need.
Okay, thank you. And I
Yes, sir.
think endoscope has two benefits. I think the one of the benefits is to see the blind spots, and another benefit is we can do the minimally invasive surgery. I think the endoscopic assistant surgery, I think the mainly used for the to see the blind spot. But do you have any idea for the minimally invasive surgery for such a endoscopic assisted surgery for clipping or extra axial regions?
Yeah, I think the minimal invasive neurosurgery is not performing a small approach, right? So if we can perform a small approach, it is good for the patient. The manipulation of the soft tissues is less, the exposure in the bone is less, but the most important aspect is that we do not produce damage to the brain tissue, the neurovasculature, or the surrounding intracranial nerves. So we have seen in our experience that when we are working with the endoscope or even the microscope, the small opening, usually, if it is well planned, it gives us the necessary pathway to go specifically to the lesion that we want to treat. There is no need to have these big exposures for some cases, but for some cases, the big exposure is better for the patient. For example, a very large chordoma, for example, that extends laterally to the middle cranial fossa, then we can use a COC approach, but also with the concept of minimal invasive neurosurgery, which is do not harm the brain, right?
Okay, thank you. There. The case you mainly showed that it was a ruptured aneurysm case, so that's why I think some craniotomy might be needed. But the small region, for example, small tumor or something, but it has the neurological symptom. But I think that you are a specialist in the vascular surgery, but small benign tumor or something is a good indication for the minimal invasive endoscope assisted surgery. Please give us some opinion.
Yeah, sure. Minimal invasive neurosurgery is thinking on the patient. So even if it's a medium size or even large size tumors, they can be approached using minimal invasive approaches. Now it's coming the transorbital approaches, for example, in which we can treat frontovasal lesions, anterior temporal lesions, and also if we use this technique to treat tumors, it is having the advantage of minimal manipulation of the surrounding brain tissue, right?
Right, thank
I
you.
think there is a good option to use these techniques for very selected patients. Obviously, for example, a very large convexity meningioma, you cannot use a small minimal invasive approach because you need to have the wide exposure, right? But as you go deep, it is usually very easy to use the keyhole concept in which you take advantage moving your instruments up, down onto the lateral portions, so you can have a wider reach of the technique, right?
Right, thank you. And also the case you showed that the last case, the endonasal approach for the thrombosed aneurysm, it was so impressive for me. Nowadays endovascular treatment is well developed, and we have less chance to approach such a midline aneurysm. So as you showed, the thrombosed aneurysm, one of the good indication, I think, but it was first time for me to see such a surgical cases. But after the stenting of the aneurysm, your case was after stenting. So So how you manage the thrombus aneurysm? The thrombus was completely removed, or how you manage the aneurysm? Please
Yeah.
give us some opinion.
In these cases, the aneurysm was a thrombosed, a very, very large thrombus inside. But from the angiographic point of view, the aneurysm was excluded because they were treated before with the endovascular therapy. So we were not having the fear to produce any bleeding during the surgery because the aneurysm was already excluded and confined into the stents, right? So we took the navigation, and in the first case, we took off all the thrombose part of the aneurysm sac. We took off the thrombus, and when we were reaching the area of the coils, then we stopped the decompression. And we verified that there was a very lax sac, and after that we performed the occlusion of the sac, but not because of there was a risk of bleeding, because the aneurysm was treated by endovascular before and excluded from the circulation. As well as in the second case was the same clinical scenario. The patient was with the aneurysm excluded with the stents, and after some time he developed this very large thrombus compressing the brainstem. So we treat just the thrombus compressing the brainstem, but we didn't access the lesion to treat the vascular part of the lesion, right?
So after the thrombectomy, the clipping was also done. Clipping was
not a complete clipping, just occlusion of the aneurysm sac.
Thank you.
Yeah.
And finally, from my question, you mentioned the importance of the cadaver dissection before the clinical setting. I also studied the endoscopic anatomy in anatomical lab so much. So, do you have any comment about the difference of the microscopic and the endoscopic anatomy?
Yeah, sure.
We have to run from the cadaver dissection.
Yes, sir. The microscope gives us a very magnificent visualization in the axial view, right? So we are used to see the surgical field in front of us. We can move the microscope around the patient or around the cadaveric specimen, so we can reach different areas. But for some instances, when you introduce the endoscope, either in the cadaveric specimen or in the patient, you see a different aspect of the anatomy. So this completes your tridimensional understanding of the anatomy around the patient. Obviously, the views that we got from the endoscopic view are very, very nice, because we have now very knitted images get it with the endoscope. So it is very fantastic to see how we can see the aneurysm, or let's say, for example, the vascular tip. And when you introduce the endoscope, then you enlarge your vision and you access to different areas that even with the most extreme positions of the microscope are not available to be seen, right?
Thank you. How is the manipulation under the endoscope and the microscope in cadaver dissection?
Yeah, I think after careful dissection of the systems, you become familiar with the anatomy, with the arteries, the veins, the cranial nerves. And I always say that it is very important to insert the endoscope with the visualization of the microscope, and then taking out microscope of your face, and then you turn your head to the screen of the endoscope. But using both hands to hold the endoscope, so you cannot produce itch around the endoscope, right? And for repositioning the endoscope for some very particular parts of the procedure, then we take in again the microscope, we reposition the endoscope, we take off the microscope, and then we go back to the screen to see the visualization of the endoscope. The endoscope can be a very dangerous instrument if you insert directly, right? Because you are not aware of what is behind the view of the endoscope. So I advise to use the microscope to insert the endoscope, and then take off the microscope so you can have the proper visualization with the endoscope. I don't know your opinion, Professor Komatsu.
Thank you very much. So from the audience, any question?
Yes, we have a raised hand from Dr. Madonna.
Thank you, Professor, for a wonderful lecture, for sharing your insights and experience with us. I know it's not within the scope of today's lecture, but you mentioned craniopharyngioma. So do you have any experience in pediatric nurses using the endoscope? And what would be your tips and tricks compared to the adult endoscopic approaches?
Yeah, craniopharyngiomas is a very challenging lesion because they can have very interesting topographic distributions. We have used in pediatric patients. I have no very large experience. I treat mainly adult patients, but the most important principle is to have, in the first place, adequate exposure. So we take off the sella turcica, we take off the tuberculum cellae, even the planum sphenidale, and for some cases we perform extended superior transclival approaches. So the first step is to expose the lesion, and after that, the internal decompression of the lesion. This is a very crucial part of the procedure because you decompress the lesion, and the parts that are bulging in the lateral portions, you can take it to the central part of your exposure. There should be no pulling away the tumor. It should be preceded all the times by careful dissection of the peripheral area, a careful dissection of the arachnoid, separation of the blood vessels that are around the tumor, and after that, you can take off the last pieces of the tumor out. Or obviously, with careful dissection of the posterior and superior part, and you need to identify if there is a proper plane of dissection between the craniopharyngioma and the hypothalamus.
Thank you. We have a raised hand from our honorable first speaker, Professor Patrick Wigren.
Thank you, Juan Luis, for a fantastic lecture. Impressive cases. I'm happy to share the same view on minimally invasive surgery and also the importance of cadaver dissections. I encourage all colleagues to, if you don't have any other way of doing it, get yourself engaged in medical education and teach while learning. I think that's important. I have a question. Are you familiar with any of the new hybrid systems? There is, for instance, SAIS has a new Kevo system, which is sort of a light version of endoscopy. Any experience at all with these hybrid microscope and endoscopic systems?
Yeah, the 800 Kinevo offers the option of the Kivo, right? This is a small tool. We have two different kinds of experiences. For some pituitary adenomas, we use the Kivo to perform the procedure, as if it was the regular endoscope. The visualization is very good. The quality of the image is fantastic. And for some cases, when we are using the microscope, the Kivo vision enlightens your surgical understanding of the surgical field. For example, for some very large pituitary adenomas, we use combined approaches in the same time, using a Dolench approach in the superior portion and endoscopic endonasal. So we can see in the same time the microscopic view through Dolench approach, and in the same time the endoscopic endonasal view for the inferior part of the lesion. I think it's very dynamic, and I think it's a very good, useful tool. Now they are trying to introduce the exoscope also to treat these lesions, and there are some systems available, and I think you need a curve to use the exoscope, not for the Kivo, for example. In the Kivo, you are familiar because you are very comfortable with the microscope, so you insert the endoscope and you have a different view. But for the use of the exoscope, you need to have a very specific learning curve. At the beginning, for example, when we were using the exoscope, I was looking at the screen, but in some time I wanted to see the surgical field. So your view goes to the surgical field, and then you remember, okay, I'm working with the exoscope. I go back again to the screen, right? I think that there should be a very specific learning curve for every technique, right?
Totally agree. Thank you very much.
Thank you.
Thank you,
very
sir.
much. I would like to ask Prof. Amador one question, that in the anterior circulation aneurysms, where you showed us that endoscopic endonasal clipping, there are around 40 cases, but there are several unpublished reports also where there are very good people who are doing it. But one problem they have encountered most often is that the clips protrude through the dural defect, and there is high rate of CSF leak. So are there any specific clips that are shorter and available in your country? What is your experience in this regard?
Yeah, there was a company, Peter Lasik, and also the Zeppelin model from Professor Pernesky, that have a very slim head of the clip. It is going to be always a problem, because when you insert the clip to the endoscopic endonasal approach, the head of the clip always goes to the sphenoid sinus. So what we have done is to cover the head of the clip with the fascia lata, and then to put some dural substitute, and in front of this, the pediculated nasoseptal flap to cover the whole area. But in the controls, you see in the CT scan, the head of the clip lies in the sphenoid sinus. So it needs to be very carefully covered to avoid CSF fistula.
Thank you. Another question is about inadvertent rupture of aneurysms. In that case, what would you advise when there is a aneurysmal rupture intraoperative?
Okay, fortunately, I have no experience with that, but we have dealt with some arterial injuries during the performance of some other tumoral cases. So when you have an arterial bleeding during the procedure, the first thing is trying to stop the bleeding using suction with both hands, identifying the precise point of bleeding, and another surgeon is taking out a piece of muscle from the lateral thigh, or there is descriptions from the abdominal wall, or even the tongue. So you take the muscle, we wrap in Surgicel, and we put in front of the defect, and we apply gentle compression. And after the bleeding is out, we put some over this area, and we take the patient to the endovascular suite to perform immediate angiogram to address the presence of a pseudoaneurysm or active bleeding. And after this, if the patient is okay, then we take the patient to the angiogram after 3 and 6 months. For the cases of vascular pathology, we have not had this kind of accident. We take the prevention to use interluminal balloon by the endovascular team to occlude the vessel while we are performing the dissection of the neck of the aneurysm. And the distal control is sometimes very difficult to obtain. But in these cases, you can have access to the distal internal carotid artery. Eventually, would put a temporary clip in this case, right?
Right. Thank you. Thank you very much. It was indeed a wonderful lecture, and we had a lot of learning, amazing videos, never seen before, I think. Thank you very much. Prof. Komatsu, any concluding remarks?
Yeah, thank you. It was so a nice opportunity for us. We have a lot of knowledge from Dr. Bergen about the glioma, awake surgery, and also Dr. Amado from the endoscopic assisted surgery. So I hope this is the good chance for the young neurosurgeon to daily practice for better their job.
Right. Thank you. Thank you very much. So I think we'll close this officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I'd like to thank both the speakers of today, Prof. Patrick Bugren and Professor Juan Luis Gomez Amador, as well as the chairs, Prof. Takashi Maruyama and Prof. Fuminari Komatsu, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and also special thanks to my dear co-host Liu Bun Singh for joining me today. I would like to mention that this is being broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 225 people who have logged in through all the different channels. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.